From the JAMA Network, this is JAMA Otolaryngology Head and Neck Surgery Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Otolaryngology Head and Neck Surgery.
Hello, and welcome to our listeners from around the world. You're listening to JAMA Oto Author Interviews. Thanks for joining us. I'm Paul Bryson, your host. I'm a laryngologist and director of the Cleveland Clinic Voice Center. Today, I'm delighted to be joined by three colleagues. I'd like to welcome Dr. Nadine Ibrahim, current PGY5 and chief resident at the University of Michigan Department of Otolaryngology Head and Neck Surgery. Welcome to the podcast, Dr. Ibrahim.
Thanks, Paul. It's a pleasure to be here.
I'd like to welcome Dr. Robbi Kupfer, Associate Professor of Otolaryngology, Head and Neck Surgery, and Residency Program Director at the University of Michigan. Welcome, Dr. Kupfer.
Hey, Paul. Thanks so much for the opportunity.
And also Dr. Janice Farlow, Assistant Professor of Otolaryngology, Head and Neck Surgery at the Indiana University Department of Otolaryngology and alumni of the Michigan program. Welcome, Dr. Farlow.
Thanks, Paul. I'm excited to be here today.
Our topic today, I think, will be of great interest to our listeners. We're going to talk a little bit about peripartum and pregnancy-related considerations during residency training. And we're all otolaryngologists, so we'll talk about this, but it's really a topic that touches many of our colleagues in other specialties of medicine and really beyond. Tell us a little bit about what motivated the group to write about this and to respond to JAMA Oto about this important topic.
Well, the University of Michigan Department of Otolaryngology Head and Neck Surgery has a wonderful residency program in many respects, but one of the things that many trainees having gone through the program understand and pass on, honestly, to those who are interested in applying is that it is a very welcoming culture to parents, whether they be women or men, whether they come in with children or are interested in having children during residency. This is something that is known throughout the program. I personally was blessed to match into the program when I had two kids and ended up having a third when I was a chief resident. And so it's not easy for any program, especially for small specialties like otolaryngology, to support that type of culture. But it was a huge appeal to me when I was a rotating medical student. And it definitely held true to that promise of that welcoming culture. It certainly has its challenges too, and we'll get into that throughout this podcast. But because of that, a lot of us talk about pregnancy issues and are interested in issues for childbearing parents and non-childbearing parents. So when this paper came out in JAMA Oto, we read it with great interest, and a little team of us got together to see if we could provide a little bit of the University of Michigan perspective, just based on the fact that we've had a number of trainees come through the program who have had children during or before the program.
Can you take us back a little bit? You know, what's it been like at other programs? What was it like as you've seen it evolve over time? You know, because I imagine not every place has it figured out.
So I think there's been a wonderful shift in the right direction at our program and probably many others as well. When I was a chief resident, as far as I knew, no female had had a child during clinical rotations. And many of the female faculty I spoke with at our institution at the time told me that they were explicitly told that they needed to wait until their training was over before having children. I, however, looked around and saw that all of my male colleagues who were married were having kids, so decided to see if I could make that happen, and it worked out. And I was incredibly supported by my program director and my chair. And I am acutely aware that many of my colleagues around the country, this was 2012, did not feel that that was an option for them at their programs. And to this day, when we talk to female residents who are considering pregnancy, we certainly see that some programs are managing this very well and it's widely accepted. And then other programs, at least the residents there, may not feel like it's a possibility for them to have a pregnancy during residency.
When you look at places that seem to provide a supportive environment or have things in place versus those that don't? Are there any, I guess it's sort of a combination of what do you hear? And then what's sort of, as we look at the literature, or at least for the shared experience of the literature, what do you see as the main hurdles for people to feel comfortable with this? Is it the fact that it's traditionally been a lot of males and less females, although trends are changing? Or is it infrastructural? Or I'm sure that's a multi-nuanced sort of arrangement.
I can speak to that a little bit. It certainly is nuanced and very multifaceted. I think in many ways, there's a changing face of surgery and of medicine overall, and that's absolutely driving some of this change and therefore driving the representation that people see in their departments and divisions that then drives infrastructure and policy change. And it all starts with awareness or somebody needing something or asking for something or just being the first to set a precedent. To what Robbi was saying earlier, where people were previously advised to wait until their training was over, there is literature that says that otolaryngologists wait 9 to 10 years later than non-medical peers before having children. And that certainly has an impact on the entire experience. And so now that things are changing with increasing numbers of residents in otolaryngology specifically, but increasing numbers of female residents in otolaryngology, increasing numbers of female medical students, female physicians overall, this will change. Training happens during your childbearing years for most people. And the more people that set the example, the more people feel empowered, supported, like they can ask for accommodations if they need them. And from there, policy changes can happen. And we're seeing that across the field, I think, and especially in a lot of recently published literature, people having recommendations for what should be included in the policies as far as appropriately supporting childbearing residents and trainees.
And my understanding, too, is that it's not just, we have the event of labor and delivery and a parental leave, then that's it, and we're back to regular operating conditions. There's more that's important, right? I think our listeners that have been parents or are parents or have gone through this journey with their partners or what have you, there's often more than just the event and the leave. Are you able to elaborate on some of the other considerations that have allowed people to be successful, or for systems and departments to provide the support that helps people be more healthy as they enter into parenthood?
There are a lot of considerations that perhaps programs and program leadership may not currently be considering in the sphere of family planning. And that is in the event that this happens with planning and not unexpectedly. But for young trainees who are considering having families, it starts with that plan in mind. And they may not be at a point, especially if there's no one in their program, they're the first to ever consider this, or if they've been hearing from others, from faculty and just other people who have come through the program before them, saying that it's impossible to have a child. That's barrier number one, overcoming that culture. However, if they're planning on having a child, as Nadine alluded to, it can be very difficult. I believe you lose half of your eggs by the time you're 30, which is when people are starting residency training. And so a significant number of female surgeons will have difficulty conceiving. And actually, I believe this came out in one of the JAMA network journals, but a quarter of female surgeons will use assisted reproductive technology. And that's both expensive financially as well as expensive in terms of time. We think of how much a resident needs to learn during their training. And so all this seems to some maybe insurmountable, and they may be struggling alone. So programs need to understand that if a woman is going through this, that even just the act of conception and then carrying a pregnancy to term is a feat in and of itself and requires sometimes a lot of support. One of the things that I think no program does perfectly, because it's a very intimate, personal journey, is when a woman experiences a miscarriage and knows about it, there is really no space to grieve, and they rely on the goodwill of the people around them, if they feel comfortable talking to, let's say, their co-residents for cover call shift or whatever it may be, stepping out of clinical duties and talking to their faculty about why that might be. Those types of experiences are not factored into this whole idea of women and men having children during residency. So that's just a little bit of what happens up until the point of having the child. But when you're pregnant, and then certainly once you give birth, there's a whole host of other considerations as well.
And to piggyback off of that, I mean, even there's a lot of discussion about what to do about call. And you may not take call in your third trimester, or maybe there's a certain period of time where you, your colleagues, or your institution have supported you and that you may not be the primary contact or the person on call. But there's some disparate practices in terms of when you take that call. Do you make it up? And what does that mean to make up your call? Does that mean you're taking twice as much call when you're in your first trimester? Does that mean that you're taking twice as much call when you have a newborn at home? What does that really look like? And sometimes our accommodations, as Janice said, it's not just what is it that we are providing, but what is the entire context before and after. And after birth, lactation is a big deal. And, whether the childbearing resident chooses to lactate or not is a very personal decision. But there's data and literature that shows that surgical residents, at least this is in the orthopedic surgery literature, but have a shorter duration of and less satisfaction with their lactation experience compared to their attendings in the same specialty. And, it's certainly not to say that it's easy when you're an attending. I think it's still very challenging, but it certainly highlights the challenges that are presented in residency. And some of the issues there are perhaps an inability or a perceived inability to ask to leave the OR, to ask to leave clinical duties, or just the sheer clinical demand is challenging. Lactation is not something that you can just do when you have a moment. It's certainly something that you need to do on a certain schedule. And there are serious health complications that can happen if we don't pump, such as mastitis, and that can have big downstream effects. And so having a policy in place, having people who've done it before, having lactation spaces, having an understanding and an awareness amongst the faculty and your peers are all critical, not just for what happens before pregnancy and during pregnancy, but also postpartum.
Yeah, thank you for that. I was also struck by just sort of the mental health support that you mentioned, around the time of pregnancy or in the event of miscarriage. What about postpartum depression and things like that? In addition to lactation support and things like that, is there much that you have experienced or seen in the literature about just postpartum depression and other things that might make that resumption of training difficult?
I think it's an understudied topic, and we talk about it in the context of being physicians and learning how to take care of our own patients who might be experiencing that. But in the context of medical training, it's underexplored and underappreciated. I sound a bit pessimistic, but I do think a lot of people struggle unbeknownst to the folks around them. And perhaps there may be an impact on their clinical, surgical, medical performance, and it may not be understood. It might be falsely attributed to, they have a newborn, they have lack of sleep or whatever it may be, whereas there might be something much more important going on, someone who is reaching out for help, but there's little support systems in place to identify postpartum depression and then support the training through it.
Perhaps some of our listeners, maybe they're trainees or maybe they're in leadership roles in their training programs. What counsel or advice might you recommend to the listener that has a leadership role in education, or to the trainee who is considering trying to family plan during residency? What sort of recommendations from a programmatic or systems level might you all share? It sounds like you've been in a supportive environment. I'm sure nothing's perfect, but what would you kind of advise the listener who is trying to influence culture at their program, or, like you said, not policy, but guidance?
I'll just say very quickly, those who may kind of see this coming up, this is such an exciting time to lead in this space. There is so much more knowledge, so much more data that we have, and we're in an exciting time where there's an opportunity for places to come up with creative solutions and to share those creative solutions, to write out helpful guidelines and policies. And it's just a really exciting time to make a big impact on the field if that's something that you or your program feel like you're in a strong position to do.
There was actually a recent publication that came out in JAMA Surgery The lead author was a graduate of University of Michigan's Otolaryngology program as well, called Providing a Safe Pregnancy Experience for Surgeons. And it's a fantastic review that goes over some different practices and policies and ways to make a more welcoming culture around this issue. I don't think it's specific to trainees, but it is a good first place to start.
Yeah, I think that it is important to have policies protecting parents and people who are pregnant in training. We happen to have a House Officer Union at the University of Michigan, which sets a standard of guidelines and policies around providing a safe experience for pregnant residents and for residents who are parents afterwards. While not all programs will have that, I think having some basic set of guidelines or policies to ensure that the minimum standards are met, but then also making sure that there's still an individualized approach, because people experience pregnancy differently than other people, and people experience parenting differently from other people. And so I think it's like anything, you have to ask people what they need. So as a leader, it's my job to try to understand the person in front of me. What is it that they need? What kind of accommodations might they need? Whether that's some time to go to their IVF appointments, whether that's a change in the call schedule or rotation schedule to accommodate their physical needs before and after delivery. And those are things that, as Nadine said, we just have to find creative solutions. I will say for me, starting out as a program director, when we didn't have as much experience with this, I reached out to my OB colleague, so the program director of OB here at the University of Michigan. They historically have a lot of pregnancies, and it's a surgical specialty like ours. And they were really helpful in giving some ideas for how we might think about ways around some of the logistical challenges that can feel impossible until you've done it.
Thank you for that. I mean, it seems like, the impossible until you've done it. It seems like a lot of times it's like, oh, we can do this, and we can have a supportive environment that accomplishes the goals of training and patient care, but most importantly, creates a safe and healthy environment for the trainee that is trying to become a parent or continue parenting or have a family or things like that.
And eventually this may hopefully evolve into a discussion of how do we make it a safe and healthy culture for everyone. We've focused a lot on the childbearing woman trainee, but a lot of the things that would make a safer and healthier pregnancy and peripartum experience are things that would help many or all of our trainees, talking about how to equitably perform call, how to give residents more autonomy over their schedule for personal needs. Even if there's female surgeons who are pregnant or in the peripartum period have significant musculoskeletal issues in surgical ergonomics. It may be unique for maybe a pregnant woman, but surgical ergonomics is an understudied topic for our trainees in general. So there's a lot of different things that hopefully as we continue to think as a field about how to better support men and women who are interested in being parents during training, hopefully this feeds forward into just a healthier environment for all of us practicing in otolaryngology.
I couldn't agree more. And to jump on that even further, while policies and guidelines are essential, as Robbi said, this is such a personalized journey that those really can be like the baseline protections, but nothing is going to supplant a good culture. Nothing is going to supplant a program and a community where you look out for each other and you understand each other's needs. And as Janice said, it goes beyond even just pregnancy and the peripartum period. It goes beyond that and can be for, personal reasons or other family issues, illness. And the thing I'd like to highlight too is that sometimes this does present a burden to non-childbearing residents, especially when call can be an issue or you take somebody out of the call pool. Sometimes that puts an increased burden on the other people in the program. And I think making sure that there's support for that as well, and that the creative solutions take that into consideration as well, so that all people feel invested in this journey and invested in each other. Because you can have a policy and you can have a guideline, but at the end of the day, if somebody needs to scrub out of a case to pump, they need to scrub out of the case to pump. And somebody is going to have to say, I got your back. and go in there and cover for you. So you cannot replace a good culture, and a good culture comes from experience, a good culture comes from representation, and a good culture comes from research and having these hard conversations.
Well, I really commend you on your work in this area to date, and I really thank you for being a part of the podcast and for sharing experiences, and I am hopeful that this is another element of contribution that allows us to continue to have these conversations moving forward. Well, thank you to the listener. I am Paul Bryson, and I've been speaking with Doctors Janice Farlow, Dr. Nadine Ibrahim, and Dr. Robbi Kupfer about peripartum and pregnancy-related considerations in residency training. You can find a link to this article in this episode's description. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.